So it's my honor to present today Dr. Karin Fox from UTMB, where she is recently moved back there. She did her residency and fellowship there after being part of the U.S. Army, and we thank you for your service. Then she went to Baylor, where really she's done most of her career. She stayed there for about 12 years. And there she is well known nationally and internationally for all her work in placenta accreta spectrum that we all encounter often in our daily lives. She created the Placenta Accreta program there. She's part of the International Society for Placenta Accreta Spectrum, and it's one of the founders of the Pan American Society for Placenta Accreta Spectrum in the US. She had almost 100 publications on placenta accreta, grants, and you name it. So I was joking that if we were to type on GPT chat, tell me about placenta accreta, it would ask Dr. Fox. So today we are incredibly lucky to have her here with us to talk to us and our expert about this condition that we unfortunately see more often, and we certainly want to do our best. So without further ado, thank you. Breakfast will be coming in a little later, so please just make your way there.
Well, thank you. That is actually one of the nicest introductions I've ever had. So thank you so much. And I'm thrilled to be here. For those of you who might not have heard, I had a little adventure yesterday with my flights getting canceled, but we made it, which is great. And it is beautiful here. So thank you so much. This is also just the lesson to hello. To the residents and fellows who may be here, that always be, on point. Recognize that every day you show up to work, it is like a mini interview, because you may end up back where you started. So, all right, these are my disclosures. I don't want to belabor them. I may still get to the talk about all of the tamponade, combat gauze, and balloons. I have no financial affiliation with any of these medications or companies or devices at this time. But again, what I want to talk about here today briefly is the practical approach to the management of placenta accreta spectrum. Just like Igor mentioned, we are seeing it more often. How to appropriately match the treatment plan to the right scenario. And hopefully you don't feel like this when you are in the OR and you see it. You're like, oh my gosh, what is happening? This is actually me at the end of a 12-mile road march after a week of doing a bunch of Army drills. But again, really talk about getting back to the basics. I think this is what we need to make sure we're paying attention to as we move forward with this complex disease process. And it's not just placenta accreta spectrum, it's the complex cesarean delivery that I want you to think about as well. Those previous ×4 C-sections with a huge window and maybe is rupturing when they're coming in because they started contracting, and there's a ton of scar and the uterus is tacked up to the abdomen. Okay, so we know that the incidence of placenta accreta is rising, right? We hear this over and over again, every publication we read. And it is, but this is actually the rate of rise of publications. So this is from PubMed by year. So I think we're actually, I think there's the kind of bias where there's where something that's really easily accessible, you hear it a lot, you see it a lot, you're exposed to it a lot, it becomes more real to you. And so we're hearing it a lot, not that the sky is falling. But this trend is real. I mean, this is even older data from 1982 to 2002 that mirrors the C-section rate. We can see here the C-section rate in the pink line, the accreta rate in the black line. This is from the University of Chicago. And there is a rise. And I'll go over some of the other reasons why. When we look here too, looking at reasons for maternal mortality, the dark line at the bottom is actually what they called adherent placenta, which is essentially placenta accreta spectrum. And notice it starts rising here too, kind of along with other disorders and morbidities. Now, you would think here that there was no accreta before 2009. But that's not true. It's just because they were looking at coding data and there's not a really good code. Now, what has gone down though beautifully in this pink line is the rate of maternal mortality. I mean, if you look back in the 1920s, it was 100% mortality. And we've been able to really drive this down by recognizing the disorder, Does anybody know when ultrasound first became common? Residents? It is a little older than me, I'm happy to say, but in the 1960s was when it really first got invented, and then it became much more common over into the 70s, 80s, 90s, and we continue to improve. So as we improve our diagnosis, our management, our recognition, we're driving that rate down. Again, there's been a lot of name changes. Abnormally invasive placenta, placenta, accreta, increta, percreta, a placenta accreta spectrum. The disease process is the same. We're trying to refine the naming because we want to make sure that we can study this well, and it's really challenging. But when we think about that historic definition, it was based on pathology. They had a maternal death, they did the autopsy, and they found some things. And on the left here, you can see normal placenta with the placental tissue kind of here at the top. Can you see my pointer? Yes, you can. Here's the villi. You've got normal decidualized myometrium down here, and you've kind of got this fibrinoid layer in between, this kind of pink stuff. And folks recognize that in these accreta cases, and this is a sample from a patient who is ultimately called increta, there's myometriums and little nests of trophoblasts within the myometrium, no knitabook or fibrinoid layer in between, and all these villi here. Now, interestingly, in more recent histopathology specimens, we're recognizing that sometimes there's massive amounts of fibrin deposition, huge amounts of stuff that really is behaving like glue. And so back, even as early as within the last 10 years or so, a lot of people are thinking of this as an invasive disease, right? Where the placental villi invade too far into the placenta. We've used that terminology for some time, almost for 100 years. But really, we're starting to think that it may be more of a defect in the uterus, and we'll go over that in a minute. Okay, so again, oldest accreta reference that I could find is actually from 88, year 88. And they're explaining in Latin here that there's copious bleeding that's coming, and the placenta is attached to the ampulla of the cervix. So it's been around for a long time, but just not as frequently. So again, it doesn't matter what we're calling this. You can call it accreta, you can call it percreta, you can call it abnormally invasive placenta, but really what most international experts have now agreed upon is to call it placenta accreta spectrum. Why? Because again, the etiology of the disease process is a little bit in question. Is it really invasive or is it just implantation? But it is a spectrum of disease. It is not just one size fits all. And every case you see, those of you who've seen these cases know that not a single case looks the same. There's similar features, but there's not the same. So it really is a spectrum, and you can go all the way from normal to a small area that's affected to big, massive bulging of the placenta that seems like it's stuck everywhere. We had one case at Baylor where I can remember looking at the MRI and thinking, why is the placenta so close to the head of the femur? And it went all the way past the psoas muscle when you're looking in the abdomen, and it encased the obturator nerve because it just bulged over. Like these little balls that I have here, the placenta will bulge out through a defect in the uterus, and it'll wrap around whatever's nearby, whether it's a vessel, the ureter, and that's what gets so difficult and sticky. Okay, so we talk about the rates that are rising. This is a wonderful slide from the National Accreta Foundation. I want to give a lot of credit to this group. This is actually a patient-centered group that was started by previous Accreta patients. They do a lot of education. They do a lot of support for families. And I have their website at the end of the slide. But they do have this slide where they're talking about the rates, but I want you to, for the residents in the room too, especially since we're talking about research day today, always know what your denominator is. Like, is it really 1 in 250 pregnancies or 1 in 272 pregnancies here? When you actually go to the studies from what these were based upon, it's not quite as accurate. I mean, again, it was histopathology confirmed in this cohort from LA County in 1 in 4,000 deliveries. And this is one hospital. This is not every pregnancy. That's talking about deliveries. In this study, we're talking again from Chicago. It was 1 in 2,500 deliveries. So again, not all pregnancies. Even Dr. Silver, Bob Silver, who's also a giant in the Accreta world, from 2006, 3 out of 1,000 deliveries. And this included clinical diagnosis, not just histopathology proven. So again, this kind of gets to why it's been so hard to study this disease well and get really good data. And the rates likely vary depending on what part of the world you're in. Okay, so why does Accreta occur? What is our more recent thinking? Not that that trophoblast is truly invasive, not like a cancer where the cells go wild and get out of control and go through. There is some physiologic invasion, I'm going to use that word, of the extravillous trophoblast, just that external layer that gets into the decidua. But what we think is it first starts with a defect in the uterus, and the most common defect that we create is that C-section scar. But any surgery that goes through the endometrium is going to cause some problems with healing. And just like any other muscle in the body, like if you were to transect your bicep, those muscle fibers never quite regenerate like normal. There's fibrosis that occurs where the scar is, and it becomes less flexible, less pliable. And again, we can have some architectural defects. But there is some really nice work out of New York from Claude Antoine, where he's looked at how we do our repairs. And when you just do a single layer closure and you can reapproximate those edges of the uterus really well, endometrium to endometrium, muscle to muscle, it creates a more natural healing, hypothetically. Whereas when we evert the endometrium, which is oftentimes what happens when we're just doing that running locked stitch. If you see that little purple ridge in the middle of your repair, that's actually endometrium. And I always thought that this looks like a nice little pathway for a placenta just to go right out to the serosa. And there is some evidence to show that actually when they've done their 2-layer repairs, now granted, it's not been validated by another individual, but other groups have looked at this too, doing different types of uterine repairs, that when you reapproximate it well and make this incision as close as possible, this niche, this little gap is smaller and the myometrial layer is thicker. So again, this is what I was getting at is it really invasion? In the normal physiologic implantation, you've got the villi, you've got these extravillous trophoblast cells. And what is their job? Their job is to implant into the decidual layer and recruit and remodel the spiral arteries, right? So that spiral artery remodeling, it opens up those spaces. It causes these big pockets of maternal blood that supply nutrients and oxygen to the placenta. And that's a normal job for this tissue. Okay, but what if we have a scar where we have this big defect and we don't have decidua there? You still have the implantation, and those extravillous trophoblasts are still doing their job. They want to support that placenta. This is where we get that big fibrin deposition. It wants, the placenta needs to stick in that area where there's abnormal tissue. And it will still recruit vessels from whatever it can find, right? Its job is to support that growing fetus. And so sometimes those vessels will come from between the bladder, maybe on the side wall, anything that's nearby. And that's what we see when we get in there. We see lots of scar tissue, lots of fibrin, and these big vessels that look like, sometimes it looks like a bag of worms or Medusa's head. By the way, when the food comes, please just get up and get food. Just do what you got to do. Again, we know these risk factors, the number of prior C-sections and placenta previa. One thing I do want to point out with this, though, that I think is really important, when you really look at the risk factors, we talk about multiple C-sections being the problem. But if we look at no previa and the rate there with no previa, oops, let me go back. No previa, the rates are far, far lower than when we have placenta previa, even with only one C-section or no C-sections before. So previa itself is also we say that C-sections are the highest risk factor, right? The biggest risk factor, but previa is actually the biggest risk factor in my mind when we look at these numbers. And it may be, we don't know, but it may be, if you think about it, that there's something different about the cervix and the tissue there. It is more collagen, there's less decidua there. We know that lack of the endometrial lining is a risk factor in and of itself. So maybe that alone causes some of that extra bleeding we see when we have a placenta previa too. So other risk factors, though, this is really important to keep in mind because we are doing more things that keep people with their uterus intact that can damage that endometrial layer, such as myomectomies, uterine ablations. This is an actual uh, hysterectomy specimen from a patient who presented at 18 weeks after having had an ablation and a tubal ligation on the same day. And when you wheel out her pregnancy, her conception date, it was the day she had her procedure. And of course, she did not actually conceive that day, but we were thinking this pregnancy was about 18 weeks, and she presented with massive bleeding, and we had to take her to the OR, and we did this hysterectomy with everything intact. But you can see how stretched out this cervix is. This was an ablation and pregnancy immediately thereafter. So any uterine resection, septum revision, repair of a didelphus, but we don't have really good data that say, what is the rate of Accreta if you have this procedure, just because it's relatively rare and it's hard to study. Advanced maternal age, this was the one risk factor cited in the 1920s, that and multiparity. And the mean age at first pregnancy is now higher than ever before. Less recognized, but it is in the IVF, the REI literature, our literature. In vitro fertilization, especially with cryopreserved embryos, is also an independent risk factor for placenta accreta spectrum. So not so much to say that you must not have IVF, but if you have a patient who has had 3 prior C-sections, she has a new partner, wants to have that last baby with them, or they have that embryo that is still cryopreserved and they want to get pregnant again, it becomes a risk factor. And it's important to at least let them know that we need to screen, look at that placenta well, this could happen, and then allow them to have that autonomy to make that choice. Again, radiation, and thankfully smoking is going down. Now, the hypothesis behind smoking is that smoking decreases estrogen levels, which then thins the endometrial layer and then potentially causes that defect. So again, because we don't want to rely, the other challenge, I'm going to shift gears a little bit. The other challenge with placenta accreta spectrum is that we have these terms, but they're based on histopathology. But when do we get our histopathology? When it's all done, right? So we can say it looks like accreta, it looks like percreta, but we really need something that helps us guide our management. And so as like at the national and international level, we are having these conversations right now about how do we really want to term this so that we can study it better together, no matter how we treat it, whether we do surgery or conservative management. And how can we help guide ourselves? It's also different from cancer in this way, because a lot of us thought before, well, maybe we can do something analogous to the TNM staging, like do something about imaging and then do something that you see at the time of delivery and surgery and then have your final pathology. But the reality is that the time to make those decisions about what to do is not when you get your histopathology. It's when you're in the OR or in the delivery room. And so the FIGO classification was published in 2019, and I'm not going to go in great depth about this, but I'm just going to say that grade 1 is the most like what we historically called accreta. 2 was what we historically called increta, and 3 was broken down into 3A, B, C, most like percreta, where A was limited to something through or in the serosa, B had bladder involvement, and C was extension to any other organ plus or minus bladder. But what we're finding is with this clinical staging system is some experts who really believe that we have to have that histopathology definition say we're overcalling accreta, and those who say we need something clinically to help guide us say it really is no different than just saying accreta, increta, percreta. It's not enough. And so we are actually really looking at altering this. So in the next couple of years, this terminology may change a little bit, or the way that we grade it will change. Most likely to come in line or bring in some of the things that have been published by Jose Palacios Haracamada out of Argentina, where he actually uses a topographic staging system where, again, if you've got superior high involvement, it's grade 1. Because again, when the placenta is high, I showed you that slide about previa being a complication. But when the placenta is high, it's not such a difficult surgery. It's when it's really low in the pelvis and lateral that it gets tricky. And his topographic staging system takes that into account. This is actually actively being studied. It's now being studied in multi-center trials, largely in other parts of the world, but we are also part of this study. So more to come. And I'm going to go over how we can actually look at that topography again in a little bit. There is also a newer pathology classification system that's trying to be a little bit more nuanced than just Accreta, Increta, Percreta, but that takes into account how much of the tissue and really defines the normal placenta. You have that endometrial decidual layer really clearly defined. That a grade 1 goes through and to the muscle, and it goes a little deeper. And then the 3A, 3D, 3E was trying to mirror the FIGO classification with histopathology, but where essentially D is deep invasion, E is extension to other organs. And it acknowledges that there may be some cases where you have the myometrial dehiscence, that niche that you can see, and the placenta is normally attached, meaning it will separate away from that scar. And that is not Accreta. That's a dehiscence with the placenta behind. And a lot of folks clinically are also really trying to redefine dehiscence only as dehiscence, not Accreta. That said, a big window with a placenta behind it and that scar can still be a very difficult C-section. So it's important to acknowledge that just because it's not Accreta doesn't mean it's not easy, or that it's easy, and does not mean that the patient may not need a hysterectomy still. Okay, so how do we look for this? How do we help our patients? We have to have that high index of suspicion. We have to be ready to see it in order to really look for it. I love this sculpture. This is a former physics scientist who became an artist. And this is called The Little Mermaid. Can you see it? You can kind of see it, right? But you notice that the light waves pass through this structure and they don't bounce back at your eyeballs. If you walk just a little bit around it, same thing. I mean, you can actually see the structure much better because those light waves are hitting the metal and going back toward our eyes, right? So the angle of incidence when we're looking with ultrasound at anything really does matter. And you can see at the image on the left, this is an ultrasound. These are the same placenta on the left. Okay, this is a sagittal image. This black stuff here is fluid, it's the bladder. And so the cervix should be down here. So we already know it's a previa. To me, this already looks a little heterogeneous. There's these lacunae, these tortuous, weird little areas that we don't like. So I'm already thinking this doesn't look right. But can I really see this bladder interface well? No. But if we can tilt the patient down, if you can put the patient in Trendelenburg, important to have that partially filled bladder so we can see the interface, and then angle the probe so that the probe is parallel to the patient's thighs. Look what happens to the bladder relative to the probe. It actually is no longer parallel to the sound waves, but you have something to bounce off of. And look at this big step off here. That is a huge defect where the placenta is pushing in toward the bladder. It's a bulge. You've got these huge tortuous lacunae, and the bladder line is interrupted, not at all normal. So again, how do we do it? Partially filled bladder, super important. There's very good evidence that we can miss about 15% of these cases if the bladder is completely unfilled. Normally behind the placenta, there's a little hypoechoic zone or a little dark line, and I've got a video that I'm going to show, so I'm not going to belabor that too much here. You can't see it though. These lacunae, if it's really big and you can see flow and it's dark within the placenta, and you've got to think could be a lacuna. Now, if it's a small circle that's right in the middle of a round piece of placenta, that could just be a cotyledon, right? But these, I can't define the shapes of those. They're tortuous. They almost look like little tornadoes. And on the bladder here too, you can kind of see, instead of a nice bright white line, you see this dot dashed appearance. These little dark spaces here, those are vessels that are behind that bladder. Especially if you can see the flow between the placenta and that bladder, you have to think that that's not normal. And of course, any bulging outside the normal plane is a problem. How many of you would like to get MRIs on all of your patients? Okay, I see one. That's wonderful. I love MRIs because you can see so much. Look, I can see everything in one screen. But we don't use MRI routinely for Accreta. It is more expensive. It's not available everywhere. And unless you have a radiologist who's really experienced at looking at the placenta, they might think it's something and it's not, or vice versa, they may miss it. So you just have to know the quality of the images, know who's reading the image, or know what you're looking at if you're looking at the image before you get that additional study. But it can be helpful in the right setting. It can be helpful. And it is used as an adjunct. I love this little cartoon where you've got two people on the side of this figure, and one is saying it's 6, the other is saying it's 9. And just because you're right does not mean I'm wrong. You just haven't seen things from my side of life. So I hear this debate all the time that we should or we shouldn't use MRI, but really my take on imaging is it's very analogous to your choice between a CTPE protocol or a VQ scan. Both are good imaging modalities. Each has its own strengths and its own limitations, and it's important to know the two. But what we're looking at when we're looking with MRIs, you do want to assess, of course, where's the cervix? And here in this patient is the cervix. You can look at the myometrium here. Looks kind of normal over here, but then we get down here and it's like, oh, what's this thing? It kind of bulges outward. And then you've got these dark bands right here on a T2 weighted image. This is a T2 weighted image because we see the bright fluid, but these dark spaces is actually, these are areas of fibrosis within the placenta, we think. That's really abnormal. And again, the bladder should not be pointy when it's partially filled. It should be a nice round oval structure. And usually, like you see this little plane of fat here between the symphysis and the bladder, that little fat plane, there's usually a very similar plane between the bladder and the uterus, but you don't see it here, it's obliterated. And I will argue, in how many uteruses do you see the placenta hang over the cervix like a paniculus? In normal uteruses, never. So if it's hanging over, you got to think that there's something wrong with the structural integrity of this uterine wall, right? So here's another image on ultrasound that I think is really important. Again, when we're looking at the placenta with ultrasound, we want to look at the entire uterus and the entire placenta. Just having single images, if you're the one reading the ultrasound, is not helpful. You really need to see the whole thing. So this was from a sweep going low to high. And you can see here, the myometrium on the left of the image, it's dark, and it comes to a point. And again, the myometrium is a nice thick muscle, right? It should be uniform all the way around. So when you start seeing points in the muscle, that's concerning. And notice this placenta just kind of seems to take over. So this is concerning for left perimetrial invasion or involvement. That same plateaued uterus that I showed you before, this is the image on color Doppler. And when you're using color Doppler, it can be helpful because you can see here, like in this upper left image, you can see that there's a lot of vascularity near the bladder. And look at this area of vascularity here that actually has a connection to this vascularity. Anything that is perpendicular to that bladder wall, you've got to think that could be a vessel that's perforating. Or when you do your 3D rendering, if it looks like just a solid hamburger patty of vessels, that's really concerning for placenta percreta. And one thing that's important to note though with your color Doppler is that color Doppler will look different depending on each patient's body habitus, scar tissue, their characteristics, right? So how can I be sure that I just didn't turn up the gain too much and then I'm making it look like it's a big old ball of vessels? Well, what you can do is if you turn up the gain all the way and then turn it down just enough so that the aliasing or these little white spots disappear, you can see a little bit of aliasing here. Then that's standardized the color Doppler for your individual patient and on that individual machine. Okay, I'm gonna play this video and hopefully my good friend Sally Collins, you'll hear her beautiful English accent talking about a newer sign called the separation sign that she studied. And notice there's no bladder here. This is actually a higher area of placenta. This is something that can be useful if you don't have that low placenta. Oh, it's not playing. Okay, I'm gonna narrate this part. But essentially what they're doing here is they're using the transducer to press on the abdomen and they want to see this hypoechoic zone open up. So you can kind of see it over here. You can kind of see this dark line over here. But when they press, here, what they're looking for is, does it open up? And here it's not opening up so much. That's a negative separation sign, not opening. Can you all appreciate that? Yeah. Okay. Look, this one, I think it has her voice on it. I'll let you hear her say it if it's working. Oh, I don't hear her voice. Okay. But that said, this is the positive separation sign where, again, when you press, you can actually see even in this midline, the placenta seems to move a little independently. And as it settles down, you can see this space open up. Okay. So which one do you think is the normal placenta? First or the second? Second, yeah, because it's separating, it's moving on its own. And interestingly, when they looked at this, of the 24 women who had a negative separation sign, meaning it did not separate, only three had normal placental separation at the time of delivery. 87% were diagnosed with placenta accreta spectrum. It has a very high sensitivity and a 100% specificity. Now, granted, this is a small cohort, but still very high sensitivity and specificity. Whereas in the these are all high-risk patients, all patients with risk factors for Accreta. The positive separation sign remained reliable of normal placental separation with a positive predicted value of 100%. When they saw it, the placenta actually separated. So this may be one of those tools that you can use if you think you've got a little bulging, but you're not sure, is it a, I don't know, I have this in there twice. Is it a, just a dehiscence, or is it truly an Accreta? The other way to help us really prime our minds, though, is to use diagnostic checklists. This is actually a pro forma that was published in 2015 to help prime us to look for placenta accreta spectrum. And you can see at the top of this form, it's a really nice, simple paper form, but it has all the clinical risk factors at the top. Does she have prior myomectomy or endometrial ablation? How many C-sections? A history of Accreta before? Is it a previa or low lying, and how close? And then it has all the most commonly recognized ultrasound signs and the color Doppler signs. If you have color Doppler, not everybody has color Doppler. And then does it look like it goes into the parametria? Yes or no? And then it asks the reader to decide what is the probability, high, intermediate, low, of focal or diffuse placenta accreta. Now, again, this is called abnormally invasive placenta at the time of this publication, but we're talking about the same thing. Now, one of my colleagues from Columbia has actually taken this form, added another page, and puts 3 boxes where he asks the sonologist, whoever's reading the ultrasound in his country, to draw the uterus and the placenta and the connections in the sagittal, coronal, and transverse planes, because they don't always have electronic medical records, and their patients may drop in at any other hospital. And so at least the patient has that form with this diagnosis that she can provide to the hospital saying, this is what I have. And it's remarkable. It's unpublished data yet, but he just asked me to participate in drawing out some ultrasounds that they performed, just asked me to draw them and say, what do I think it is? And while we all differ just a little bit in what we think the topographic classification is, those drawings are all remarkably similar. Here are some of those drawings, in fact. So you can see here, when you're looking at this image, just look at these huge lacunae. Those are massive. Look at this bulging, and look, it encompasses the entire cervix. It's anterior, the bladder is involved, and it's bulging laterally and low. So if you saw this as a surgeon, even though it's not high tech, that tells me so much more than just hearing, oh, it's a procreta or a stage 3, right? And this is actually what they found at the time of surgery. So then how are we going to manage these patients? How many of you do conservative management where you deliver and leave the placenta in place? I'm seeing a lot of head shaking and like mortified looks. They do that in France quite a bit. But if you read the data, it makes it sound like it's way better, right? The blood loss is lower, all the things, but it can take up to 9 months to resolve completely. There is a risk for recurrence, and you're not removing the affected area, right? And if you read the fine print in a lot of those studies, not every patient is a candidate for conservative management. If it fails or somebody starts bleeding, they still have to do the hysterectomy as a delayed procedure. The one site, let me get this right. The one-step conservative surgical management, the focal resection and repair, this has been used with great success, especially in South America and now also in Indonesia, in the appropriately selected candidate. So again, the triple P is like this as well. It can reduce surgical morbidity. That's the primary goal, because you're not going in and digging out the ureters, and hopefully you're avoiding the bladder. But again, if the placenta is very, very low into the cervix or very, very lateral into the parametria where all the vessels are, there's nothing to repair. You don't have that healthy tissue to repair it. So not everybody is a good candidate. If you go in doing the wrong technique in the wrong patient, you may actually cause more harm. And of course, cesarean hysterectomy, that's what's used in 80% of centers worldwide. It does require a strong surgical skill set, as does the uterine sparing technique. But we know there's a much higher rate of urinary tract morbidity, adhesions, and other complications. And so why is it so hard when it's low and lateral? Like, I always like to remind people, especially folks who don't do these surgeries often, that we've got the pelvis is like a salad bowl with a little tiny cereal bowl down below, and where the bladder and the ureters and all the vessels are is in that narrow portion. And so if you've got a little placenta up here that's a little higher, maybe above the bladder or just at the dome, you've got some healthy tissue. Let me go back if I can. You've got some healthy tissue in between here where you can repair. But if it's like this and it's bulging over everything, you're in the worst part of the pelvis. And you've got the most important structures there. So it is highly morbid. But you can see also why you may not be able to cut and repair this too. So despite all this, how have we been able to drive down morbidity and mortality? It is by really trying to learn from one another. And again, this is where the multidisciplinary team comes into play. In study after study after study, whether it's, again, just in Utah, in Houston, or in the International Society, looking at a multi-center database, multidisciplinary expert teams were found to have reduced blood loss rates despite increasing morbidity, and decreased ICU stays and mortality when the team was in place. Again, and how does the team work? Why is it so important? We do get better outcomes from shared expertise, but it has to be a functional team, right? It's not just a group of people coming together. We have to trust one another. We have to communicate well. We need to be able to debrief and really learn. We want to make sure that we've got 24/7 coverage for these patients because we can plan all we want to. But again, even in our data from Houston, we found that 46% of patients had a delivery that was ahead of schedule. We can schedule it 34 to 35 weeks like ACOG recommends. We can schedule it 34 to 36 like the International Society recommends. We will still have patients who start contracting and bleeding and need that emergent unscheduled surgery. So who's going to come in? You need to know who to call. But when we work together often and we actually start maintaining our competence, it's like having a dance partner, an orchestra, or a band. When you start practicing together, you start learning how each other works and moves and where do we go and how do we fit. Not every team is going to look the same between centers though. As long as we've got all of the proper components that fit together well, it doesn't matter if you've got 6 people or if you've got 9 people, as long as you have enough to get the job done and do it well, and the full skill set, that's what we want to make sure we have. And then of course, when we work together, we can debrief, reduce variations so we improve our outcomes. Or if we're going to vary, it's because we're tailoring the appropriate treatment to the appropriate patient, but we're still trying to standardize as much as we can. And we can also iteratively improve, not just individually, but as a team. I mentioned the 24/7 care. So what happens if you're out in a small community hospital, you're doing coverage and you have that patient drop in, and maybe you're at a place that only has 4 units of blood total for the entire hospital? Well, Danny Carusi from Harvard and Brett Einerson from Utah created this wonderful flow chart that I think is now in the SMFM guidelines. But you can actually assess your patient and ask, have you already started the surgery? Yes or no? And it all comes down to this stop, is the patient stable or unstable, right? If the patient is unstable, you've got to mobilize your resources. You have to take care of the patient there. If you cannot move them, you've got to start doing what you can. But again, if you have to deliver, avoid the placenta. If I had one piece of advice, do not cut through the placenta. But then pause. If the placenta is still intact, she's not bleeding, you can give a little Pitocin and keep the uterus contracted. Is she stable? If she's stable, consider transport. You can transport before the surgery, of course, but maybe after the delivery of the baby, you can transport that patient to the higher level of care. Or maybe you're the receiving center and you are ready, waiting for that patient to arrive. Again, if they're unstable, that's when you continue mobilizing your team, consider hysterectomy, get as many friends with you as you can. But there's many places where you can pause. You can deliver, close the abdomen. You can deliver and look. Maybe you start the surgery and you say, oh, that is an Accreta. But if mom and baby are stable, you do not have to deliver the baby. Close the abdomen, transport the patient. Again, I'm going to shift a little bit to try to get back to the basics. I say this all the time, time is blood, time is life. Time is everything. Delay is going to be the biggest cause of additional mortality if things get started and you don't recognize it. So the key is to be ready. I'm sure you have a transfusion protocol. I'm sure you have access to your hemorrhage carts. That's been a big part of the AIM bundles. But we actually started an Accreta cart at Baylor so that all of the instruments are where you need it. The beauty is it's not just for Accretas, it's for any cesarean hysterectomy that occurs because of atony. And that way, if you've got that brand new nurse who's just oriented in the OR how to circulate, and she's the one because the senior nurse got sick. She can find it. You can tell her to go to the Accreta cart or to your HIST cart. And it doesn't have to look like this. It can look like a regular, anesthesia cart, as long as people know where to find all the supplies. And again, I mentioned checklists too. You want to have preoperative checklists. We started putting medical alert bracelets on our patients who came in with Accreta because again, a lot of people were coming from far away. They may live 4 hours away. And while we try to relocate them well before they would start contracting, I can tell you, I had one patient who I said, you must be here in Houston by 28 weeks. And she called me at 27 weeks, 4 hours away, and said, I'm bleeding heavily into the toilet. What do I do? And I said, you put me on the phone with your ambulance driver and I'm going to call the hospital and we're going to call ahead. So you can plan all you want to, but sometimes patients will not follow the plan. And speaking of planning, extra planning required for your Jehovah's Witness patients who have Accreta or who decline blood products. I've had many. I would urge you to please talk to them about all of their options very clearly. They don't have to have red blood cells, but maybe they'll accept cell saver. They maybe will accept the fibrinogen concentrates or Kcentra. So individual patients may have their individual options. This is actually a photo from a normovolemic hemodilution. It's harder to do this nowadays, but you can actually set up blood bags on a series in patients who have enough hemoglobin, take off a bag of fluid, leave it connected to the patient, close the stopcock, give them some crystalloid back, do it 2 or 3 times. And then as your surgery proceeds, you start with your most dilute blood and then give them back their most concentrated bag as your surgery proceeds a bit. And we did this for a patient who had a pretty impressive Accreta, who refused blood, but she accepted cell saver, she accepted normovolemic hemodilution, and thankfully she accepted cryoprecipitate because fibrinogen is the one thing that is going to dip the first and the most when you have that massive hemorrhage. Again, make sure you know your team well. One of the team approach, one of the most important people on the team that again is the center of what we do is our patient. So we have to work a lot with our patients too in their decision-making, what their goals are. But again, this is where I have that conversation about how are we going to approach? Are we going to try to take a look and see and just do that focal resection and repair, or do we need to move directly to hysterectomy? Or again, for those who really do want to try conservative management, or you leave the placenta in situ, we have to make sure that we know what we're dealing with beforehand. What is your team ready to do? If you're not ready to accept a patient who has a placenta still in place, who comes back 4 weeks later bleeding, then maybe a hysterectomy at the time of delivery is the more important option. What is the patient's desire? I mean, again, fertility is not the goal of the more conservative management styles. It is possible though, and there's great data that up to 80% of patients who have either the true conservative management or the one site repair can get pregnant again and have successful pregnancies. But again, our first goal is safety of the patient and reducing morbidity. But again, if they live really far from the hospital and cannot make it back, you just have to consider what their ability to return is. Again, another thing that sometimes people overlook is something very simple. Now, granted, this is Celsius, but I like to turn up the hours every time I go in the OR now, especially my new place. It feels really cold to me, so I'll just quietly go turn up the temp. Why? Because when patients are cold, you can get into this lethal triad of bleeding, which causes coagulopathy. When you bleed, you then vasoconstrict and you become hypothermic. And interestingly, coagulation factors work about 10% less for every 1 degree Celsius the body temperature drops. That's why we like to use a warm lap and a bear hugger. And we like to keep the ORs cool to keep us comfortable because we're under those lights and things. But one of the easiest ways to keep your patient warm, and you want fluid warmers and all those things, but just turn up the temp in the OR. They do it in burn units, they do it in pediatric units. I think it's important for these. And it's also, if you're delivering a premature baby, keeping the room warm is also helpful. But then when you start vasoconstricting, not only do you get cold, but then you're getting less oxygen to those peripheral tissues. And then your Krebs cycle kicks in and starts shifting from aerobic metabolism to anaerobic metabolism. You start getting peripheral acidosis, which then makes its way into the circulation. And then we get this vicious cycle. Also really, really important if you do have to give a massive transfusion is what happens with that transfusion. The citrate in the bags chelates calcium you get hypocalcemic. Any lysed cells increase the potassium, and you can get into these electrolyte derangements that can very quickly lead to arrhythmia and a cardiac death. Very important. We actually ask to have our circulator check underneath the legs every 15 minutes to look for vaginal bleeding, because you may have a pristine surgical field and it's all coming out on your shoes if you're not careful. Or your anesthesiologist, if they're telling you like, hey, did you just put pressure on the aorta? Her blood pressure just dropped. Look under the drapes, because it may be that it's actually vaginal bleeding that you can't see. Again, hopefully if you have a massive blood loss, it looks like this and not just all over the floor. I mean, at least this is neat and tidy, but that's a lot of blood, I would say, right? So it is really important to make sure you're recognizing the bleeding as it's ongoing. We talk now a lot about quantitative blood loss versus estimated blood loss. I would much rather have an ongoing, relatively accurate estimated blood loss where somebody's telling me, I think it's about 500 cc's as I'm doing the surgery, rather than focusing only on weighing all the pads and then getting that number at the end, right? I need to have that information from my nursing staff as we go. But other things that can help, of course, a self-retaining retractor. We want all of our hands available. So again, if we can have something like a book Walter, that can be really helpful. A headlamp so we can see deep into the pelvis wherever we're looking. And the most important tool, communication. Really clear communication with everybody. Closed feedback, super important. So how are we going to make our skin incision? A lot of people will use that vertical midline every single time. Does anybody prefer a horizontal suture or incision for these here? I've actually started using them, but make them really big, and not in somebody who's morbidly obese or has a big known history of scarring, but you can actually get quite a bit of exposure if you do it the right way. You have to be prepared to still go vertically, but if you create a really nice wide horizontal incision, you can get the fascia in the midline and still get to the baby well. But what are the pros and cons? You've got optimal exposure with a vertical midline. You can get to that aorta if you need to put pressure on it. It's more hemostatic because there's not vessels that go through the midline. And you may have some reduced superficial nerve injury laterally in the skin. There is an increased risk for wound separation and infection, though, a longer operative time when closing, and a risk for incisional hernia. But again, risk for the horizontal is that you may have to extend the skin. And again, here's an example, again, from my good friends in the UK about using that really long horizontal suture, or not suture, the incision. But you've noticed they made a really wide curve, and I'll actually go from 2 centimeters above the anterior superior iliac spines, along the old scar and up. And they're really taking the fascia off of this muscle very, very high, so that they can adequately separate the fascia in the midline. I may actually, but you can see here where they're measuring it. Lots of exposure. And then as long as they can get up above, they're getting the bladder down here, as long as they can get above the area of affected placenta, make a high fundal incision on the uterus, keep it as hemostatic as possible. Here's where they're actually extending that fascia more. They've got even more space now. As soon as the baby's delivered and the uterus contracts, then you've got plenty of space to exteriorize even more. And that way you're not fighting the bowel when you have everything packed, because it'll come down through your incision. Now, again, we want to make sure we're looking intraoperatively. This is actually the posterior side of this placenta. Look at this bulging into the perimetrium. This is where I was grateful we had a vertical skin incision. And notice you can use electrocautery quite a bit to keep it hemostatic. This is really important. We want to spare the blood loss for where we cannot avoid it, rather than try to allow a little oozing here and there. Here we're actually compressing the myometrium. We're borrowing from fetal intervention, where they open the uterus and try to keep it hemostatic. By placing these stay sutures, again, you're closing up those sinuses that fill the uterus, opening very hemostatically. If you get a little oozing, you can put a little clamp on there. Or you can actually pinch around that area of suture, just a little pressure from your fingers. And, we published this use of a linear stapler and cutter that's usually used in GI surgery, because it seals the edges and opens the myometrium. You notice we're above the amnion, so we're not at risk for cutting the baby's finger. I mean, there have been some case reports of that too. You got to make sure you're protecting the baby. Works really well. But the other alternative is you can put your 2 fingers into into that hysterotomy, elevate. Is this the same one? Yeah, it's the same one. But you can elevate and then have your partner put clamps all around and do the same thing without having to spend the money on that stapler. And you notice once you splay those clamps, you've got plenty of room to deliver the baby. What you want to do though is make sure if you know you're going to keep that placenta in place, we're not going to disrupt it. We don't want it to detach. Keep the membranes in those clamps and as you suture. You can take like a double looped PDS and just really quickly suture that closed, something with a big needle, but you want to incorporate those membranes. Some groups will actually do put a tie around the internal iliac artery just to have it ready to go. You can certainly ligate these. Now, this is not as commonly
mobilize a
done.
portion of the internal iliac
here's
artery away from the adjacent
this
structures in
Sebastian.
order to safely pass a ligature around it. Repeatedly identifying the anatomy is helpful in maintaining orientation and avoiding complications during this step. Once again, a lower is helpful in accomplishing this.
Yeah. Notice they're very
Here,
delicately.
some of the vessels from the
They're very delicately using that instrument to tease away the tissue. They're not using the tip or the point, they're using the heel. I'm going to fast forward a little bit.
is helpful in accomplishing this. Utmost care is required when dissecting underneath the internal iliac artery to avoid damaging the internal iliac vein.
Have to pay attention
The
to that.
ureter can be observed vermiculating safely away from the operative field. The vessel is then grasped and elevated with a Russian forceps while a lower frees the vessel from the underlying structures. This is performed in a lateral to medial fashion to avoid injury to the adjacent external iliac vein. A non-absorbable suture is then passed around the artery and tied 3 centimeters from the bifurcation of the common iliac artery. This is to ensure that the posterior division of the internal iliac artery is not compromised during the process. A second free tie can be placed distal to the initial ligature to help avoid recanalization.
There you go. So some folks will actually place this suture and just have it ready to go before actually getting into the dissection. So this is another technique that folks can use. And the way that they dissected out this internal iliac is kind of the same way that we would dissect out the ureter and pass a vessel loop, for example, and just hold it so we can keep it out of the way. Okay, let's see here. Other techniques, again, identifying the vaginal fornix is really, really important. Here you can see we've got this big EEA sizer in an end-to-end anastomosis sizer, this metal tool that you can see at the beginning of this video. You can also use a sponge stick, works very well. This is actually the posterior aspect of the uterus. And you can see here where we have the ureters on vessel loops so we can identify them well. We've dissected them out of the field so we can avoid them during the placentation. But you can also take, let me go back here, sorry. You want to take sometimes a posterior to medial approach. The worst part of the scarring in these cases is almost always right in the midline. And if you can at least get around enough laterally to get those uterine arteries ligated, sometimes taking this posterior approach and walking around it, here we go. You can walk your clamps around, the ureters are already out of the way, and you will clamp those uterine arteries and get them taken care of, and then get to the part that's a little more stuck. Okay, and again, I mentioned that not all patients need the same treatment. This is again another rendering from our good friends in Colombia about their criteria for deciding whether or not a one-step conservative surgery is feasible or not. The placenta should affect less than 50% of the circumference of the uterus. You need at least 2 centimeters of healthy myometrium between the cervix and the lower portion of the affected tissue. And again, then you can get around it as opposed to the big diffuse placenta. And how do they do that? Again, they will open in the skin in a horizontal fashion, expose the upper portion of the uterus, not necessarily deliver out the fundus, but they make sure they make their incision above the affected area of the placenta. Now, is there a little bit of placental tissue here? Yes, but you can do a Ward's maneuver where you go up and get the baby out from around that affected area of placenta. Then what they will do is actually, what they'll do is they'll cut around the affected area of placenta, repair the sides, and then close the hysterotomy. Before they actually cut this last bit of placenta out though, they put 3 big sutures, one here, one here, and one here, because there's all this vasculature that will come up from the lower segment. They call it the copouterine vessels, and at least that will tamponade before you make this cut. And then you just have this little piece of hysterotomy that is for your pathology, and the patient's niche, affected placenta, old scar is all removed. And they found that because you're not getting into where the ureters are, it's actually a shorter surgery, a more cost-effective surgery, and the blood loss is equivocal. Now, what if you do have that placenta that's completely stuck to the bladder? You can't avoid it. You have to either cause bleeding or take a little bit of the bladder. Again, getting as much blood supply as you can is important. You can help identify the bladder margins either by lifting up the Foley, or easier, just clamp the Foley and let the bladder fill or backfill the bladder. That way you can see the margins and hopefully avoid it. Hopefully, again, you're avoiding that trigone, because that's where the damage can be greater. This is where I would absolutely want to have your urologist in the room before we make this incision into the bladder, if you can, or if it's massive, massive placenta. If it's just a simple incision in the dome, that's where you call somebody in and do that repair. But you want to make sure you're, again, have at least a 2-layer repair. You check to make sure it's watertight, and this is where we'll have to leave the catheter in for a few days. I can remember being really proud that we dissected off this massive Accreta from a bladder, and minimal blood loss, looked great, but the backside of her bladder looked like a wall of vessels. The issue is too, even in those patients, didn't bleed, didn't open the bladder. My advice is leave that catheter in a little longer if there's a bunch of vessels that you've ligasured. Why? Her catheter clotted, her bladder got over distended, and even though those vessels were sealed when we got done, they opened up when her bladder got overfilled. And so she actually had hemoperitoneum, and we had to go back and then we gave her transfusion, got those vessels sealed. Had another patient who had a very similar picture. I said, just leave that catheter in for 5 days. It worked beautifully. Again, don't forget, you can consider a uterine tourniquet if the placenta is high. This will help decrease blood loss as you're working until you get to the hysterectomy portion. And again, don't forget that you can use other tools. So things like cellulose matrices. This is one that actually has thrombin and fibrin in it. It's expensive, but it works very well. They can use it on a liver lac or an aortic laceration. Or combat gauze that's saturated either in chitin or kaolin that activates the coagulation cascade locally. That can be really helpful to temporize. Now, these trauma pads have to come out. The cellulose can stay in. But again, it's another way to apply pressure. You can certainly do aortic occlusion, reduce the perfusion pressure to that uterus. And this is an actual picture from a textbook from 1922. Please don't do this. But it illustrates the point that you can compress the uterus. And this was a postpartum patient who the belt was tied so tightly that the femoral artery pulses disappeared. So they effectively stopped the circulation there. You could use an intra-aortic balloon. We've used this before. I think it's one way if you have that really big case. I've actually had a couple patients where I've thought, you know what, if we didn't have that aorta occluded, this patient surely would have died. I had one patient who had a 9-liter blood loss despite having this inflated 3 times. Massive, massive, massive Accreta. However, you can have somebody who can cross clamp, or again, put a tie around the aorta if you've got a vascular surgeon. Have it ready to tie down gently if you want to. And then don't forget that manual aortic compression works. Now, you don't just put one finger on the aorta. We will actually sim this later for those of you doing the sim. But again, what you're doing is you're elevating the uterus out of the field. You're moving the intestines out of the way. You find that bifurcation with lap or not lap. You use the palm of your hand and just put pressure. And you should put sufficient pressure that you do not feel the flow of blood underneath your hand. If you feel that thrill, just like you're feeling the thrill of the carotids, blood is getting through. Now, this is a great way to know too if somebody's giving good chest compressions, because guess what? You can feel that thrill when chest compressions are being well done. But here's a really good example. This is an actual case where we had a arterial line in the event that we needed a aortic balloon. Our trauma surgeon said, hey, just call me. I'll thread it up if you need it. Previous times 4, extension into the left parametrium, had that femoral A line in place. You can see her arterial tracing here. And then the clamp on that left parametrial side went right into placenta, missed the uterine artery. And so we went from less than 500 cc's blood loss to 4 liters within 5 minutes. So what do? Thankfully, my fellow knew exactly how to give good aortic pressure. You can see here in the A line that was transducing that femoral artery, her pulse pressure went from here. And now you can see it decrease when the hemorrhage started. It went to 0 with the pressure. That means she was giving good aortic compression while anesthesia was doing the MTP. And the oncologist and I were getting that vessel controlled. And as soon as the vessel was controlled, you can see that her pulse pressure returns. But again, and this is a span of here, you can see this is 15 minutes here. So this is less than 5 minutes. We were calling that trauma surgeon, but by the time he got in there, he's like, you guys don't need the balloon. We're like, no, we needed it 3 minutes ago. So balloons can be handy, but if you're going to place it, here's my advice. If you're going to place it, either have somebody who's there in the OR who can just put it up, or again, have it in place, ready to fill in the event you're going to use it. But again, we have found, as have our other colleagues across the world, that again, not everybody actually needs that balloon. When we've looked at our data, only about 20% of the patients actually ever had it inflated. So again, we want to make sure we've got good outcome. I want to leave you with resources, and certainly we want to get on with a resident research day. That's the most important part. Please check out 2 things though. The videos that I showed you about the surgical technique, there are about 25 videos here at this Placenta Accreta spectrum. Note that there are 2 S's here with really great instruction. And lots of great YouTube videos talking about the topography staging and the 1-step surgery, and invitations to participate in multi-center research at this YouTube. And I thank you for your attention and your time.
All right, great talk. Thank you so much. I hope to have you around, or my team around, when we get to the next one, because these are hard. So any questions? The microphones are rolling through the room. There's a question back there.
Thank you.
Check
Oh, I don't know where
Pat.
she went. I have 2 questions. One is, in terms of risk factors that you should be worried about, any data on like resolved placenta previa? So previa in the pregnancy that has resolved, does that increase the risk?
Oh, so if there's previa, but it resolves,
Yep.
is there increased risk? We actually have looked at that data a little bit, and we think that there may be a slightly increased risk. But when I see it resolving, I'm actually more reassured than if it doesn't resolve.
Sure.
Does that make sense?
Yes.
Yeah.
Yes, but it does raise your concern, like your
Yeah,
pre-delivery
if you had it
control, but-
initially, you've got it, you still have to think in the back of your mind, like, she did start with a previa,
Sure.
right? And especially if it's in the area where we know she's had surgery before. So, we just had a case at, just this week where somebody came in abrupting, and I got the phone call at 4:30 saying, we think we've gotten Accreta, there's blood spilling on the floor. That's terrifying when you get that call, right? And I can live 15 minutes away from the hospital now. But what had happened was she had a uterine torsion. So what they saw was the vessels of, the uterine vascular bundle, not a big percreta. And when they cleared things out and found the lower segment, it was actually the posterior side of the uterus when they finally got the baby out. So you have to know where your surgery is, and, then you can assess your risk.
My other question is, C-sections for ectopic pregnancies. like
Love
CFF,
it.
And what, like, whether that is considered, I know you're MFM, so you're not often seeing like these patients necessarily in the first trimester or the early
Mhm.
second trimester, but is this considered part of PAS? It seems like it is, obviously, but is there a connection in the research? Like,
Great
what is
question.
the collaboration?
Yeah. Okay. So Ilan Timur-Trish from New York also has got a wonderful case series, and there are 2 registries, the CSP registry, and there's a registry out of OHSU in Portland, looking at this exactly. And yes, when you get that pathology specimen back after a CSP, they will say Accreta, percreta. And we think, if you hear Ilan Timur-Trish talk, he says that CSPs are baby Accretas. And I fully think they are. It's exactly that mechanism. It's a implantation of that embryo into that scar, whether it's in the niche or on the niche. And now the great debate is, of course, I think I actually just emailed him and said we need to write a paper, because again, our guidelines thankfully still say this is an ectopic pregnancy. That was very intentionally included, because again, I'm in Texas where we can't necessarily treat everybody. We can for ectopics though, and we can when it's a threat to patient life and safety, thankfully. But what's happened with our laws right now is that it's put a chill on treatment, and so there is delay. But yeah, absolutely. You can resect. And there are some people, I've had patients who absolutely refuse. In fact, that case that went all the way to the obturator nerve, she came in with a CSP and said, no, I'm not going to treat. No, I don't accept that. She was Catholic and said no. And I said, okay, well, if you rupture, if you start having pain, you must come in. Massive Accreta. Yeah. 70% of CSPs will end up with a Accreta. Pardon me.
Any other questions? So I have a question.
I do.
Oh, sorry, Luther.
The
No,
boys-
go ahead, Dr. Igor.
Go ahead, go ahead.
Hi, Luther Gaston. I'm one of the nocturnists. So three things. One is if you could just briefly comment on where do you think conservative management of placenta accreta spectrum disorder will be going versus all the surgical stuff that we just saw, and then in terms of morbidity for the patient. And so if you could, and then I have a question in terms of that first uterine layer, not including the endometrium. Do you think, and I don't know that we know this, but a lock versus a not lock layer in terms of strangulation of that tissue, and trying to keep that tissue as nourished and everything as we can. And the third question is about how valuable do you find TEG in these cases?
Great questions. Okay. First of all, I think conservative management, again, because we're really good at becoming experts in the one technique that we use, and it's kind of hard to learn new techniques. I will say that the group in South America and that last resource that I left about the one-step conservative surgery, this group is actually doing weekly meetings on Saturdays, teaching people from around the world how to assess this. Here are the pitfalls. Here is what we can learn. Here's how we do it. Here's the approach. And here's when you must abandon. It's like using forceps or an instrument delivery. When is it indicated? When must you stop and do the hysterectomy? So I think that the one-step conservative management is probably going to be the appropriate approach and the most accepted approach for a lot of people. Leaving the placenta in situ purely, it is effective for some patients. Pardon me, but not for all. And they have to be able to come back to the center that treated them. And so if they live far away, they may drop into some ER bleeding and it could be a disaster. So there is an ongoing trial in Utah looking at conservative management, leaving the placenta in situ. But then when we leave the placenta, we're also leaving that scar. It's never repaired. So more to come. I think we need to do more studies. And I was just telling some of our residents that the time that you start getting comfortable or should start getting comfortable managing placenta accreta is about the time you're ready to retire, which is also the challenge, right? Because again, by the time you feel comfortable, you've got to pass on your knowledge. And residents today are doing less than a quarter open abdominal hysterectomies than I did as a trainee. So if they're not getting the surgeries, how are we going to teach them? What are we going to do? We have to become really creative. And then as far as TEG, yes, TEG and ROTEM, very useful if you know how to use it and you have it available.
And then in terms of closure of that layer, because we've been closing uteruses for just crazy amount of time. And what do you think is the best technique? Although we may not have the most solid data, I've gone to not incorporating the endometrium after seeing your talk at SMFM. But is there, in terms of single layer locking versus not locking that first layer, do you think that strangulation of that tissue affects that viability of that tissue, or if we just don't know right now?
I think it could actually, because you're right. If you think about what happens after we suture the uterus, we give a lot of Pitocin, the uterus is contracted. What happens the next day? We go and we feel the fundus, it's the umbilicus. So the uterus then relaxes. But what doesn't relax? Our suture, right? It's like having that belt that's too tight after you eat your big Thanksgiving dinner, right? And or your Spanx on, whatever you choose. And so there may be something to that. We just don't have the data to really to say it is absolutely hypoxia that causes that niche. But again, I have to agree. I think that just really trying to put the endometrium to endometrium and muscle to muscle is the goal. There are some folks who will do interrupted sutures because you don't have that locking, or there's a study out of Turkey also where they used kind of almost like a baseball stitch and then cinch it down almost like a drawstring stitch, one in the endometrial layer, one in the muscle layer, and then sew over. And they also found that the niche is smaller. So I think it's more about recognizing the tissues appropriately and putting them together well, but not over strangulating. And okay, I think
All
we're out
right.
of time.
We're
All right,
gonna,
thank you.
thank you so much.